All right, everybody. Welcome to Denver Health Workers United Teach Yourself. Can everyone hear me okay? Let's try this. All right, am I audible to people?
Loud and clear.
Sweet. All right, so this is, I think, the fifth installment of Denver Health Workers United Teach Yourself. We're a wall-to-wall open union for all Denver Health employees working together for a voice at work on issues we care about. This month, we are talking all about ketamine. Next question here is, can people see my notes?
Your notes are hidden.
Cool. This is my first ever time doing one of these, so I want to make sure it goes well. All right, we're talking all about ketamine tonight. Couple of warnings. I tried to simplify most of the language and information in here for the sake of practicality. There's a wide variety of people attending. So feel free to jump in and ask me to pause if you want to know more or if something doesn't make sense. Just because it's simplified doesn't mean it makes it any less complex. Also, this lecture is going to touch on some kind of uncomfortable situations politically and interpersonally, so be ready for that one. The more we allow this stuff out in the open, the less harmful it gets. So, yeah. So by the end of the day, I want you all to know what ketamine is, how it's used, how our patients are cared for in the ambulance after ketamine administration, what agitation is, methods for controlling the agitated patient in the ambulance, and how patients and why patients are sedated pre-hospitally. Hoping for kind of a quick lecture with some clinical pearls and time at the end for general questions and comment, because everyone loves talking about ketamine and I want to hear what all of you think about it. So quick history. Ketamine's precursor, phencyclidine, PCP, was discovered in 1956 while discovering for a non-narcotic anesthetic which would preserve cardiopulmonary function during anesthesia. During initial trials with anesthesia and a severe and prolonged emergence delirium was documented with PCP, and the compound was deemed unsuitable for human use. Ketamine was synthesized later in 1962 as a short-acting derivative of phencyclidine by Calvin L. Stevens. The emergence reactions of ketamine were considered similar to ether anesthesia at the time and deemed acceptable by physicians. The first ketamine trial was performed on inmates at Jackson Prison in Michigan, so that was interesting. This was considered a success with several dose-dependent effects of ketamine being documented. At low doses, you have analgesia. A higher dose creates a psychoactive effect, and higher than that, you become dissociated completely. The overall incidence of side effects was about 1 in 3 volunteers. The frank emergence delirium was minimal, though. Most of the subjects just described sort of strange experiences like a feeling of floating in outer space or having no feeling in their arms or legs. This was important in the history of medicine because prior to this, there was no safe, stable, non-narcotic option for anesthesia other than ether, which really is a less than ideal medication due to its corrosive and flammable nature. Outside of medicine, ketamine is widely known among the general population as a horse tranquilizer or club drug. In the 1960s and 70s, after it gained FDA approval, soldiers injured during the Vietnam War were given ketamine for anesthesia because of its wide margin of safety. Largely due to this field use as anesthesia in Vietnam, phencyclidine and ketamine became widely known for their psychoactive effects and became popular drugs of abuse. This spurred the creation of the DEA in 1973 and the creation of the drug scheduling system. That's just a fun fact. But back on topic, since the 70s, ketamine has been found to be a useful medication for a number of conditions. However, we're here mostly to discuss it as a treatment for agitation. It's found use as a pain medication and anesthesia, sedation, also for severe depression, as an induction agent in rapid sequence intubation, for refractory status epilepticus, and mild to moderate asthma exacerbation. It's a very, very useful drug. So, how does ketamine work? Ketamine is described as a non-competitive NMDA receptor antagonist. But what does that mean? Putting it simply, each neurotransmitter, which is in search of its receptor. The receptor won't work until paired with the transmitter. Some transmitters want to propagate signals and some want to make them more difficult to send. Antagonists reduce receptor activity, agonists increase receptor activity. A non-competitive antagonist will bind to the receptor without stopping its transmitter also from binding. This interferes with normal function of and reduces the receptor activity overall. A competitive antagonist, by contrast, will bind to the receptor and block its transmitter from also binding, preventing receptor function. NMDA is one of several neurotransmitters which bind to glutamate receptors. Glutamate receptors themselves seem to be related to neuroplasticity, or the ability for the neural networks in our brain to grow and reorganize as we grow and learn. NMDA, therefore, is involved in a diverse number of functions in our brains, including memory, awareness, and perception. So, layman's terms, ketamine binds to the NMDA receptor on the cell in our brain and stays so that NMDA cannot attach and perform its normal functions. Depending on dose, this can decrease sensation, cause disturbance in perception and awareness, or dissociation, the separation of the mind from the body and senses. This is how ketamine causes anesthesia without any of those pesky narcotic side effects, like respiratory depression. This is also why ketamine was considered so safe for administration in the field in Vietnam. So if it's so safe, why is there controversy? Why are we talking about it? So we have this from an Associated Press report. Elijah McClain was walking home from a convenience store August 24th, 2019, when someone called 911, saying he looked sketchy, was wearing a ski mask and waving his arms. Police arrived, and after struggling to handcuff Mr. McClain, officers brought him to the ground using a carotid hold, which restricts blood to the brain and renders someone unconscious. When medical responders arrived after about 15 minutes, paramedics injected him with ketamine. There's a video saying at police request. He went into cardiac arrest en route to the hospital and died several days later. So immediately, what are the red flags here? Why was a patient who was already controlled by the police given ketamine? Why are there reports of EMS giving a drug at the behest of police? Why did he even die in the ambulance? The first two could be chalked up to a provider in stress who was not in control of his situation. As for why Elijah died, there are many possibilities, and we'll address those here coming up. I would speak more frankly, but I really don't want to speculate on that. It is important to know, there was a lot of talk after this of ketamine overdoses being given and the suspected toxicity there. There was a study done in 2001 that determined the oral safety ratio, LD50, for ketamine was 600 milligrams per kilogram for humans, or for rodents. So extrapolating from there, we'd say 4.2 grams of ketamine for a 70 kilogram human. So the dose given was unlikely to be lethal by itself. So following the death of Elijah McClain, paramedic use of ketamine became a topic nationally. Interviews with a variety of non-emergency physicians voicing their concern with technicians using powerful anesthetics. And before discussing the indications for patient restraint in ketamine, as we really should just set one thing straight. Police do not ever, never make medical decisions for paramedics. Anytime that's happening, that's a recipe for disaster, which we can see in at least, I think, 2 of these headlines that are just really shameful. So here's some excerpts from a Denver 7 article published October 15th of this year. They said they found Denver Health had used ketamine 481 times in nearly 4 years, not specifying for which causes they were using ketamine. West Metro Fire paramedics gave it 22 times for excited delirium this year. Thornton Fire administered ketamine 11 times since 2019. Arvada Fire used the drug 3 times in 4 years. Clear Creek gave it only once in 3 years, and Aspen has given it twice in that amount of time, I assume. Aurora Fire has given 25 times in 3 years, with 60% of those cases giving the maximum dose of 500 milligrams. So this begs a few other questions. why is Denver Health using between 4 times and 100 times as much ketamine as these other agencies and not ending up in the news like these other agencies? Also, kind of what do lay people and anesthesiologists really need to understand about our use of the drug? Simply looking at these numbers, we can already make some large assumptions. We know from just talking to each other that ketamine is given in the minority of sedations. It's not our first line for these things. And with these numerical disparities, we can say with pretty significant confidence that Denver Health ambulances are seeing more combative patients and sedating more patients than all of our surrounding agencies. Like everything in medicine, it all really comes down to practice, and the more frequently you're in a situation, the more capable you'll become at managing it. So then really it becomes about why, how, and when a patient is being sedated. So let's answer why. Sedation is one of the most overhyped and most important paramedic procedures in EMS. It's right up there with nasal intubation. It is really popular for talking about it if you're a paramedic student. So it's really important also to dispel some of the emotion around this procedure. An aggressive patient is not always receptive or even able to engage with verbal communication. This makes our job very difficult because many life-threatening and time-sensitive illnesses or injuries can present with aggression and combative behavior. It's in the best interest of our patient and ourselves to be able to chemically sedate our agitated and combative patients when they are not redirectable. So, how many of these conditions on this page could be tested for pre-hospitally with a combative patient in a dynamic scene with no bystander history? I mean, so let's put ourselves in a situation. Imagine you and your awesome paramedic partner have just arrived, code 10, going emergent to 2222 Lawrence, the rescue mission. You were sent there because staff found someone who was altered. No other information. Walking up, people are shuffling around, smoking outside, getting in the way of your stretcher, you're trying to get inside, figure out what's going on. Go through some double doors in the cafeteria. There's also a bunch of people walking around, a bunch of them heckling you. Towards the back, you find like a group of firemen standing over your patient. He's a 20s male, rolling around on the ground, diaphoretic, yelling at everybody. Staff say they saw him convulsing at some point, and he obviously has a hematoma on his forehead. Our patient denies having any problem. He's not been injured. He's okay. He says he's fine. And he also says he's going to fight anyone who touches him. In helping him up to his feet to put him on the stretcher, you can get a quick pulse and feel he's tachycardic, at least in the 140s. So, looking at this nice up-to-date table, how many problems could this guy realistically have? And how many of those could kill him if unaddressed? Just from what we know about our guy, there's maybe 13 of these 19 problems on this list that he could have. Maybe 6 or 7 of those are potentially fatal, or at least could cause some permanent disability if left untreated for a long time. Also, it's important to notice that the last 3 on the table, schizophrenia, personality disorder, and antisocial behavior, all of which could be a factor for our hypothetical patient, don't immediately preclude decision-making capacity. Before we go sedating people, we really need to be exceptionally sure that they don't have decision-making capacity. We can't go around taking people's rights away without any kind of reason. So very quickly, what goes into decision-making capacity for paramedics? 1, the ability to evidence a choice. The ability to maintain and communicate stable choices long enough for them to be implemented. So the patient can say, I want to come with you in the ambulance, and walk up to the ambulance and sit down in the stretcher. Or conversely say, I don't need to come with you and I'm fine and I'm going to walk away. You know, some people have a surprisingly hard time with that one. Number 2, the ability to understand relevant information can really just be assessed by asking the patient to paraphrase what you've told them about their assessment. As long as they can really repeat back basically the gist of what you've said, then we can say that's there. The third part is the ability to appreciate the situation and its likely consequences. Very subjective, like most of this. Just can the patient really understand the risks? Normally that's also assessed just by asking them to repeat, you know, if I keep going with this and it's not treated, I could die. If they understand that and they say they understand it, then that's a-okay. And then the last one is the ability to manipulate information rationally. This is, you know, patient's behavior, mood, the stability and appropriateness of their affect, their perceived perceptual disturbances. This all plays a part. Someone could have the first three and they're also talking to 4 or 5 people in their head, and you could maybe say that it sort of starts undermining your perception of their decision-making capacity, because really any kind of delirium, deficit, denial is a big one, and just thought disturbance, they all really modify and affect these abilities. So talking about our guy, maybe he has epilepsy, he seized, he hit his head, he's coming out of his postictal state to a bunch of firemen hassling him, and he's just hostile. Maybe he has meningitis, he's delirious, and he's gonna go into a status seizure pretty soon and die. Maybe he didn't seize at all and he's just high on meth and that hematoma is like an hour and a half old. Maybe it's all three. I mean, there's really no way to tell, and he's not going to talk to us, neither is anyone else. So next, what is agitation? Simply put, it is demonstrating verbal or physical aggression or the potential for aggression. These behaviors exist on a continuum, as is well illustrated in the Richmond Agitation and Sedation Scale. It's also pretty well summarized. There's a recent episode of MCRIT where they talked about ketamine sedation. So I'm just going to repeat their ideas here. For them, there were 3 general categories of the agitated patient. Those who are just upset, generally only need the attention from one provider to de-escalate, kind of like the demented, altered grandma kind of thing. These people are not a risk to themselves or really anyone else. The low-risk agitated patients, patients who are a risk to themselves but not the provider. So, for example, the drunk man who's swearing at you but can't stand up. Then lastly, the high-risk agitated patients who are not redirectable and pose an immediate risk to themselves and to the provider. When uncontrollable, these are their ketamine patients. Assessing all of this stuff, especially pre-hospitally and especially in the middle of the rescue mission, involves weighing a lot of risks in a crisis situation very quickly. It is really easy at this point to mistake one category of patient for another when you're moving quickly. So for every patient, each provider will perceive a different risk level on any given situation, just because of their sort of where they're at currently in their mind and their previous experiences. So, risks of not medicating agitation. We all know the act of restraint is risky, legally and physically. So why do we do it? We want to decrease our risk for patient or provider injury. We want to really do a good job with our physical exams and assessment, and it's really hard to do that on someone who's fighting us and isn't sitting still. Not doing good exams, not doing good assessments, not paying attention leads to worse outcomes, and tying someone to a stretcher and leaving them there can lead to excited delirium. So we can't just leave our guy in the shelter without being 100% sure he can take care of himself and isn't dying. So with him being unable or unwilling to answer our questions and just generally being uncontrollable, we have to restrain him to our bed and take him to the hospital. But putting restraints on this agitated person is inherently risky. When it's done methodically, with care, this increases safety, but it is never totally risk-free. So during restraint, every limb should be assigned to a provider with one controlling the head and another 1 or 2 placing seatbelts and restraints. That's 6 to 7 people ideally for restraining one patient. So I mean, 2 paramedics, 4 firemen, perfect. You can see with this wonderful illustration of my cat, our first seatbelt always goes across the legs right above the knees, very tightly. Second goes under the armpits, across the chest, up high. And then lastly, that goes the wrists. That's just so we can really minimize how much kicking and bucking and leverage they can pull from their hips and keeps everybody safer. An IM injection during or prior to restraint can really reduce the risks for the provider and patient throughout this whole procedure. And physical restraint really should always be an avenue to chemical sedation. Patients pulling at restraints for prolonged periods of time can injure themselves, interrupt rhabdomyolysis, or if they're in an agitated state for a very, very long time, they can develop sympathoadrenal hyperactivity and the loss of hierarchical integration or homeostatic control, which is excited delirium. So there's a lot of variation reading studies about what exactly excited delirium or agitated delirium is. Some seem to really imply that it's only drug-induced, and that some people say that it can be psychiatric, but overall, any hyperadrenergic state in which the patient is minimally to nonverbal, violent, with highly elevated vital signs, and imminently headed towards cardiac arrest and death, we can just call that excited delirium. Here's it was first described in 1832, and here's a nice little table just sort of listing off how they described it and how it was seen and just the different studies that have happened over time. But a lot of them have a lot in common. You know, out of control, psychotic, fear, hyperactive, confused, hallucinating, paranoid, violent. Like it's everything, and all of them seem to end in this stupor exhaustion, complete exhaustion, cardiorespiratory collapse, things we really don't want for our patients, which is why we need to really do our best to keep them calm with verbal redirection, de-escalation, and eventually chemically sedation. Make sure we're all staying safe. All right, so when do we use ketamine? Slide is straight from our protocols. The adult patient with signs of excited delirium where the safety of the patient and or providers is of substantial concern. So what does that mean realistically? There is no uniform presentation of excited delirium. If we can't ever say 100% that our patient was hyperadrenergic and about to die versus just terribly distressed and antisocial. But with like everything pre-hospital, this is in a gray area. And it's also very likely this decision was made under great duress. So as long as we're functioning in the best interest of our patient, educating ourselves as best we can, staying safe and using our skills, things tend to work out. All right, so let's paint the scene. You, your wonderful paramedic partner, and your paramedic student, you're all pulling up in your super cool ambulance, lights and sirens, to the really nice part of Park Hill. As you're pulling up to the scene, you find about 2 square blocks of the nice part of the neighborhood cordoned off by what has to be every single cop in District 2. They have a man on his knees in the middle of the street, handcuffed, and that guy is just sweating. You can see him from a block away, like you've never seen a person sweat. He's screaming and yelling, "They're gonna kill me, oh my God." PD says they didn't chase him at all. He surrendered immediately. He's been increasingly paranoid and just unconsolable. And the neighbors and all their kids are just out on their nice porches filming you with their cell phones. So what do we do? Well, right now, he's being controlled with handcuffs. He's kneeling, he's breathing and looking around. He seems pretty stable. He's agitated, but not requiring intervention immediately. He's staying still. Would you say that he's more risk to himself, more risk to everyone, not a risk at all? What's everybody think? Well, I'm going to say he's agitated, but more just a risk to himself at this point. So he's going to get sedated. We know that. But with what? What options do we have? When really, what are these each truly for in the ambulance? We have Haldol. Everyone knows that one, the first generation antipsychotic. We give it 5 to 10 milligrams IM or IV. Not the most rapid onset or most effective, but if your patient's just a little lippy, that's usually a safe bet. You know, you don't want to put them all the way out. You just want to cool things off before they get too bad. Midazolam, Versed, so benzodiazepine. We can give that one IM 5 milligrams twice, or we can do IV 2.5 milligrams twice. More rapid onset, some more powerful medication. Also kind of a shorter duration. And then ketamine's kind of our last resort. We give that IM only for agitation, 5 milligrams per kilogram, with 500 milligrams being the max. Very quick onset, very powerful. With each of these things, they have positives and negatives. Monitoring is also important for any sedated person. However, certain drugs should be making you more concerned for certain things in your patient. For instance, Haldol, we're normally watching for a prolonged QT interval, maybe a drop in blood pressure. So we will assess their vital signs regularly, like we always do for all of our patients, and put them on a 4-lead usually. Versed, that causes more CNS depression, decreased respiratory rate, can impact oxygenation. So we would put them on, say, SpO2, capnometry, and check their vital signs. Ketamine, there's a lot more to look out for with ketamine. If your patient isn't sedated enough, they can start an emergence reaction. They can come out of it and be hallucinating and not know what's going on and be just as agitated as before, but now they can't tell what planet they're on. We can have hypersalivation, laryngospasm, plus they're an unstable patient. Like we said, excited delirium is a sick person. So we'll be checking their vital signs, put them on the 4-lead, get CAPNO, SpO2, repeated careful physical exams. Just keep a very close eye on these people. Also, ketamine can produce a sort of wide variety of cardiovascular side effects up and down. It seems like the normal intoxication dose causes more tachycardia, hypertension, and then like overdose can send it towards bradycardia and hypotension. So our patient, likely category 2, kind of like we said, good candidate for Versed. He's in the middle of the street, angry, agitated, in handcuffs. We don't have an IV. We're not going to get an IV quick. So IM it is. We can pop him right in the shoulder with 5 milligrams, and then hopefully by the time the handcuffs are off and he's all the way restrained on our stretcher, he'll be safe. Going super smooth, get him in the ambulance, nothing has changed. Get him on the 4-lead, he's up at 160, you get a systolic blood pressure that's approaching 300. While you're doing that, he is giving his really best effort to just tear the pram off the floor of the ambulance from restraints, and like it kind of looks like he could be successful. So, ketamine. Now's the time. 500 milligrams right in the thigh. He's a big dude. He can take it. All right. So you give it, you sit on him, you wait, you make sure he's got a patent airway. Slowing down enough for a good physical exam, maybe some procedures. Now that he's getting more controlled, very likely he's still tachycardic, hypertensive, acidotic, sick man. So we can do the cool DG thing. 2 big boy IVs, fluids, supplemental oxygen, and tidal. All good. Code 9 to the hospital. Maybe do a 9 setup. Everything's moving pretty smooth here. On the way in, we're doing our good physical exams. We start noticing he's really salivating, like a lot, so much. And maybe he's not protecting his airway. Is this intubation time? No, Peter, it's not. This is easily treated by repositioning his head, using some adjuncts, maybe some suction, and worst case scenario, maybe a 0.5 milligram of IV atropine. Give him a reassess after a couple minutes, I guarantee it's all better. Hanging out, walking away, you know, you're down to like, let's say Clarkson and 17th, getting there. And you know, his breathing pattern's getting kind of strange. It's slowing down a little bit, it's getting irregular, and it's this weird honking noise. What do we do? Do we intubate him? No. We start BLS. Laryngospasm is really scary, especially when you don't even know what it is. You want to take good care of your patient. He doesn't want to die. You don't want to be on the news with a dead ketamine patient. So let's fix his laryngospasm. Right now, his vocal cords are spasming shut, reducing airflow. We know from school that this man needs to breathe. So we open up his airway with the Larson's maneuver, seen here on the left. Very firm pressure up. You can kind of feel it under your ears, right at the top of your mandible. There's a little notch. It's actually called the laryngospasm notch, or Larson's point. But very firm pressure there while you're doing a jaw thrust will relieve his laryngospasm enough for you to kind of bag valve in some oxygen. Most of these last less than 5 minutes, so you can BLS your way through it, no problem. But they can recur, so it's good to keep a close watch. And always do what you think is best. Always control your patient's airway however you need to. Cool. Made it to the ER. Talked to charge nurse, got our room, wheeling him down to R8. All of a sudden, he's up. He doesn't know where he is. His eyes aren't focused, and he's puking all over himself, all over the hallway. Now what do we do? Well, the attending ER physician intubated this patient and took him up to the ICU, where he spent about 10 hours getting sober from his cocaine overdose. And he got discharged successfully in the morning. So, good job, everyone. We saved a life thanks to appropriate ketamine use and using capable, evidence-based patient care. Great job. So there we go. This is the end. Now we know all about agitated patients in the ambulance. We know about our drugs, doses, and routes, and we know what to look for and how to intervene if something's going wrong. So I want to hear from all of you people. Tell me your ketamine stories. I told you at least 1 or 2 of mine. And then if you have any questions about anything, I'll all the Elijah stuff, how the news is going, the ketamine waiver with the city, your own personal ketamine practice. I want to hear all about it.
Hey, thanks for the sweet talk. In the pediatric ER, we use ketamine primarily for all of our conscious sedations. And recently, I was doing conscious sedation for a 15-month-old who got bit by a dog, and they were fixing up his face. And I was watching this toddler whose heart rate had previously been in like the 90s, 1-teens, jump up into like the 20 teens, which is expected with ketamine. But I just had this thought that I was like, man, I really wish that this kid was on like Versed or fentanyl or something that I had a reversal agent for. What do you do if your patient gets too much? Is there like a protocol? Is there just kind of supportive care?
Yeah, I mean, as far as we're trained, it's really just supportive care. My understanding of ketamine toxicity is it's short-lived, and you can support the patient through it. The most serious repercussion that I know about is the laryngospasm, and we do have ways to intervene on that. So yeah, I mean, it is always kind of a gamble. There are, I mean, definitely side effects with ketamine, so we always want to be careful. But we only ever really use it when we are kind of backed into that corner. So I would rather have that kind of uncomfortable, unstable patient for 20 minutes than get my head ripped off. So I don't know, maybe someone else on here can speak to if they have any kind of protocols to.
I was going to say in the ICU, coincidentally the pediatric ICU, I've not seen a ketamine overdose myself. I think the normal situation, we'd probably see that in our unit, unfortunately, is accidentally administering the wrong dose if that were to happen. But I mean, Jacob's completely right. Supportive care is mostly what you can do. If you end up giving the problem with kids is you're a lot more likely to give a overdose that is several orders of magnitude larger. So, giving 1,000 milligrams to a person when the max dose is 500 and they're 82 kilos is very different from giving 10 milligram per kilo instead of 1 milligram per kilo to someone who's 3 kilos. So a lot of the things that we would probably focus on would be the sequelae. I think what we would worry about the most would be laryngospasm, which again is managed supportively for the most part. The other issues that I'm aware of that you can run into is neurological. So extreme overdoses, there are reports of seizures and other cardiovascular issues, but there's not really a whole lot that you can do. You can treat symptomatic bradycardia with something like atropine. And you can, if seizures are clinically significant, treat those. But there's nothing directly that can be done for it. And ketamine doesn't respond to, there are certain drugs like propofol or bupivacaine overdoses. You can actually inject them with lipids, and that'll help. It soaks up the drug and helps prevent toxicity. But ketamine, unfortunately, doesn't seem to respond to lipid sink as well as some of the other neuroactive drugs do.
Awesome. Thanks so much, you guys. Really appreciate it.
Yeah, and thanks, Paul, for jumping on that one. That was really cool.
So you give one of the sedative medications first, and it doesn't work. Do you have to clear ketamine through the base, like your base physician? Or do you just go with it, Jacob?
I mean, I've always called base because I feel like every time, most of the times I've given ketamine, it's just because nothing else has worked. Just a little story time. I had a really fantastic call with one of my old partners that it was some dude that his wife had passed away unexpectedly, and he was taking it really badly. And about 2 days afterward, he stabbed himself in the chest with a steak knife, like pretty deep. We found the knife. It was like a good 3 or 4 inch stab wound. And he was up on the second level of this little house, like crappiest little windy landing staircase. And his 3 35-year-old diesel mechanic sons were like having a hard time keeping him down. And we gave him, I think, I don't know how much Versed, and it just wasn't slowing him down at all. Like everyone was getting tired. So we just ended like, okay, like ketamine. And we called in for that one. Or at least I called in while my partner was upstairs sitting on him. But yeah, and they were very gracious about it. I mean, I feel like midazolam and ketamine mix pretty well. I mean, so is that what your experience has been? Have you ever called in for it?
I never had to call into it. I've usually just called for more Versed, and it's actually worked. But occasionally it hasn't. They're still kind of bucking it, and I just let them deal with it at the hospital. I've never gotten to the point where Versed hasn't at least chilled them out to a certain extent. My 2 ketamine experiences have been very easy. The first one was like true excited delirium in the Safeway off like Broadway in Alameda. Guy being held down by 5 firemen, been like knocking stuff over, and we just made a decision to go straight to it, and it worked wonderfully. And he had a nice, comfortable ride over to the emergency room after he was properly sedated. And then the second time was more of like a violent person that was in PD custody that we knew that we wouldn't all be able to handle, and we more of an issue, and we just sedated him with the ketamine. And same thing, it was like comfortable ride to the hospital. So I've never had a like laryngospasm or hypersalivation or anything like that. And I've heard that some people are quick to go to atropine with a hypersalivation when like you could just manage it with a little bit of suction or like BLS airway management, stuff like that. So I don't know what your thoughts are on the atropine thing.
I mean, I've given atropine before. And like being honest, I feel like it was mostly just so I could say I did. It did help him. Like I was minimal suction, like every like maybe 15, 20 seconds, just give a little but yeah, after like the second time I just gave him a little bit of atropine and it dried up right away. So I mean, a little bit of both. Like BLS is fantastic, but also we have these wonderful medications that are also not harmful in those small doses. So why not use them?
So I know you don't want to
Unless it's appropriate.
speculate. I know you don't want to speculate, but what are your thoughts that went down with the Elijah McClain situation?
I don't know, I imagine my thoughts are similar to everyone's where, I know all about Aurora Fire. I know their history. I know their sort of standard. And it's not ours. So, I mean, I would assume, given the dose and his size and the fact that he, on the camera, didn't seem to be really an excited delirium, it was probably like a ketamine overdose, I mean, for what they needed. It's debatable if they even needed to sedate him.
So do you think it was
I mean, I don't know. Probably
unwitnessed laryngospasm or hypersalivation or
like
something?
laryngospasm. Yeah, I mean, that's what it sounds kind of like, is that he went into cardiac arrest on the way to the hospital and they got him back and he was alive for a couple of days. So it kind of sounds like a respiratory arrest sort of thing, but I wasn't there. And
got a comment from Ben Fleischer. Regarding Elijah McClain's case, at least per scene footage available online, law enforcement never requested or directed EMS to give him ketamine. He was arrested on scene. So in your opinion, Jacob, do you think it was more the ketamine or more like the improper management of the side effects? Or like you can't have one without the other, I guess. But
yeah, I mean, I don't know, you shouldn't really be doing one without the other. And like the fact that he arrested on scene, it sounds like with what Ben's saying, that sounds almost more like the carotid hold that the police were doing. But so I've heard people saying too that he like had passed out at least twice before the paramedics got there. So I mean, it's one of those things, like really who knows? But I would assume that the fact that he was given ketamine, something improper, or like I said, you're under stress and there's a new situation and someone says it, you just kind of go with it and don't make the best decision because you're kind of in that lizard brain mode. You're not functioning at 100%. You're just out of control. That's when a lot of our mistakes happen and they can have consequences.
I'm curious if you have any thoughts on the Colorado Department of Public Health reviewing the use of ketamine and what, if anything, you might expect out of that.
So our medical directors gave us a little email about that one. Right when they started the review, lose our waiver. Orders of magnitude above what the other surrounding agencies. I think we'll be okay, but I think some of these agencies, I mean, that's when you should be asking questions and doing this investigation. And so I'm glad they're doing it, and hopefully they make good decisions. But yeah, like this lecture, I was trying to imply with this lecture, I mean, really ketamine can and should be a very safe drug to use. It does have some specific side effects that if you're aware of and are expecting, you can manage pretty easily. But it's just the problem when people don't take the time to learn about these things and aren't expecting the stuff, that things go wrong. So hopefully everything goes okay. If these agencies get to keep their ketamine, they get to also learn about it some more and can use it more safely. That can answer your question.
Yeah, it does. Thank you.
Yeah.
I think, unfortunately, you see a little bit of the effect of that you tend to see with a lot of drugs that either have a storied past or have at some point been scheduled by the DEA. And great examples are like cannabis, cannabidiol, LSD, ketamine. Like, these are drugs that have a lot of potential for legitimate medical use when used by trained professionals and when used in ways that have been studied, but the way that they're portrayed sometimes in the media is not really representative of of a responsible stewardship of the drugs. It's kind of reactionary, a little bit knee-jerk, unfortunately.
Yeah, I think that's definitely true. I mean, in like doing research for this, reading some of those news articles, there was so many quotes from like some guy who runs like a ketamine depression clinic in somewhere, like anesthesiologist that does only elective surgeries, talking about like, I've never seen excited delirium before. I don't know what they're talking about. Or like, how can you give these people this drug? Like, they don't even know what it's for. Like, you know, they don't know what they're talking about. That 500 milligrams of ketamine, why would you ever give a human that? Like, you know, I think a misunderstanding. And I think there's like Paul was saying, that there's a perception of the drug and a perception of the situation that isn't exactly true. It's very reactionary, which is why we try and spread the good word, let everyone know what's going on and how these things are used realistically.
Hey, Jacob, tell us about the K-hole. What's the K-hole and why do I hear about it all the time?
So the K-hole's a thing. I also want to answer Ben's question. So about the criticism that excited delirium doesn't actually exist as a recognized diagnosis. So I think that's kind of like those, you know, you read a study about it and it says like excited delirium is only with cocaine overdose, or like, you know, that there's a very like limited set of things that could actually truly be excited delirium. But I mean, I've seen it myself at least a couple of times. Someone who's just becoming so agitated and they're so ramped up and they just push themselves so far that their heart rate shoots up into like the 190s and their blood pressure's 260 something. Like, those people aren't stable. They're no longer a medically stable person. They need true medical help. They're not just a combative drunk anymore. So, I think even if it isn't an actual recognized diagnosis, it's a functional diagnosis, and those people do need help. And then the K-hole, I mean, that's pretty much what we're doing. The K-hole is like with the 3 tiers of ketamine, right? We have the like first level where you just kind of get like a nice analgesia with no real psychoactive or dissociative effects. Then the next level up, you start having like the recreational dosing. And then you move past that and you become dissociated, which is what we do to people in the ambulance. You know, we are trying to give them the dissociative dose so their mind leaves their body and they don't fight us anymore. So I think the K-hole is really just a bunch of people at raves or whatever that took just slightly more than they should, and they ended up dissociating. You know, fall into a dark hole in the sky and don't come out for 20 minutes.
Have any of you experienced the K-hole? Have you ever been treated with ketamine?
I've never been treated with ketamine. I'll say that. What about you, Paul?
I have, actually. Not recreationally, but I've been therapeutically treated with ketamine for procedural sedation. And it is, I don't like propofol. So, okay, to like preface this, when I'm at the doctor, I'm very opinionated about what drugs they give me, obviously. So I don't like propofol, and fentanyl and midaz gives me like a terrible hangover. So I opted for ketamine the last time I needed to be procedurally sedated. And it is truly a very unique experience. Obviously, there's a little bit of a window where you have partial dissociation, and that's really where, and I've never used it recreationally, but from what I understand, that's where the most interesting high is that partial dissociation, because you're aware of the fact that you're dissociated, but you're not like blacked out from your surroundings yet. And you kind of slip through that little partial dissociation before you kind of completely go under. And it's really hard to describe this sensation, but it really does kind of feel like, you know, most sedating medications, you just kind of feel sedated. But with ketamine, you are aware and things just kind of white out, and you just kind of realize that you can't feel your limbs all of a sudden. And it's just a very, very different sensation. You're like very aware for a split second that you're there, but not that the rest of you is. So it's definitely different.
And that sounds like exactly what I want to do to my patients most of the time, you know? Like I want them to be fine. I don't want to hurt them. I want them to have a nice time, but I also don't want them to like be screaming and yelling so much and like try and kill anybody. So that's perfect. I'm glad that it seems to be such a nice experience. Well, sweet, everyone. Any more questions, any concerns, any comments, any really cool stories?
I'm just gonna say one more thing, just because I love ketamine. So I'm a huge advocate for it in pediatrics. A lot of people in peds are afraid to use it, even though it has a lot of really potentially great. And I was actually thinking of an ED case where we had a kid who, I'm trying to remember the circumstances, but like somehow he had a knife dropped on his back or something, and he had like a big laceration on his back, and the kid was hysterical and screaming and just like not in any situation where they could actually do anything to help him. And so we ketamined him, and it worked like a charm. But we've also used it for intubation for asthma patients, because one happy side effect is that it causes bronchodilation. So it can be particularly useful for intubation in asthma patients if they're they're static to the point where they need to be intubated. And the other thing is, I don't know if you all have ever heard the whole thing about like you can't use it in head trauma patients. There used to be like this long-standing idea that it increased intracranial pressure, and so if you had patients that were at risk of increased ICP, that you shouldn't use it. And interestingly enough, a lot of the new data has suggested that that's not true at all, most likely. That actually it's a very safe drug for patients with head trauma. And so in situations like that, it might be preferential to use that for procedural or even for intubation in those that have head traumas. And we use it in the ICU in a drip form for pain control as well. And we use it in the youngest patient I've ever used ketamine in, I think is younger than 2, older than 1, but younger than 2. I don't remember the exact age. So it's pretty safe down to some relatively young ages, and it's really, really useful. That's it.
I know we have it for analgesia too in the ambulance. It's I feel like more infrequent to give that for pain control than it is for sedation. But I think our primary indication for that is just someone who needs pain control but is either somehow allergic or like maybe in like opiate recovery or something. There's some contraindication for opiate use. But I've used it I think once or twice, and it seems like if you can get the dose right, it's kind of hard to do a really controlled drip in just like a macro chamber.
Right.
But if you can really nail it, like it seems to be very, very effective.
Yeah, every time I've used it for pain, I've had like wonderful results compared to like giving somebody like 300 of fentanyl and they're like, oh, I still hurt and like I feel like shit. And ketamine, usually it's just like the lower dose and they're like, it's happy time, I'm all good. And they walk into the ER and the nurses are like, this guy's having a good time, we're all having a good time, and they're not zonked out on fentanyl. So I've had good luck with that for pain management.
Have you guys ever had to reverse emergence reactions with ketamine or treat emergent reactions?
Yeah, usually just like 2.5 of Versed IV, I think is the standard. And the one time I've had to do that, it worked perfect. You know, you start like picking his head up off the gurney and like eyes are opening up and it's like, oh, let's go back down. Like, and it worked great.
Cool.
Well, right on, everybody. I think this was a successful talk. It'll be up on YouTube here shortly if you want to share with your friends. And yeah, I think next month, Natalie Durkovich, one of the SICU nurses, is going to talk about blunt cardiac trauma. And then after that, we'll have another talk from one of our nurses, maybe about critical care. And I think Paul himself wanted to do one, I think in March, about pharmacodynamics, pharmacokinetics, I think something like that for the non-pharmacist. So we have some exciting stuff coming, and hopefully I'll see you the next one in a month. You all have a good night. Take care.
Thank you.